And Bismillahirrahmanirrahim. Students, today we will be starting the new chapter of the cardiovascular system, that is the heart. We have already discussed the diseases of the blood vessels, and I hope that you have understand. So today we will be going to start the next chapter, that is the heart. So this is the normal anatomy of the heart. On the left side of the figure you can see the gross photomicrograph of the heart, and on the right side this is the ultrastructure that is showing the superior and the inferior vena cava that are carrying the deoxygenated blood, that is highlighted in blue, to the right side of the heart, comprising of the right atrium and the right ventricle. And after the blood passes to the right ventricle, with the help of the pulmonary arteries, it is transferred to the lungs, where the lungs convert this deoxygenated blood into the oxygenated blood, and with the help of pulmonary veins, this blood, oxygenated blood that is highlighted in red color, is returned to the left atrium, and from the left atrium the blood, after passing through the left ventricle, is carried through the aorta to different parts of the body, the head and the upper limbs, and through the abdominal aorta to the trunk and the lower limbs. So this is the basic circulation, the circulatory system that you have to understand. This is again a photograph demonstrating the normal circulation, the right side of the heart that is containing the deoxygenated blood, and the left side of the heart that is carrying the oxygenated blood. So the basic pathologies of the heart, the diseases that we will be discussing in this chapter are, number one is the heart failure. That could be either the left heart failure or the right heart failure. And then the heart diseases, that could be congenital heart diseases, that include the left to right shunts, the right to left shunts, and the obstructive congenital heart diseases. And then the most common cause of the heart disease, the ischemic heart disease, that includes the angina, the myocardial infarction, the chronic ischemia, and the sudden cardiac death. Then the next diseases of the heart includes the hypertensive heart disease, the left-sided and the right-sided, and then the valvular heart disease, including the atrial stenosis, the mitral valve prolapse, the rheumatic heart disease, infective and the non-infective endocarditis, the carcinoid heart disease, and the diseases related to artificial valves. And then the last are the cardiomyopathies, that could be dilated cardiomyopathies, hypertrophic, and the restrictive cardiomyopathies. And then the inflammation of the heart muscle, the myocarditis, and then the pericarditis. So these are the common heart diseases that we will be discussing in this chapter. The pericardium, the effusions, the pericarditis, and the tumors of the heart, the primary tumors of the heart, and the effects of other primary tumors on the heart, and then the transplant related diseases. So now coming to the vital statistics of the heart. The heart is about the size of the fist, and in females the heart weighs approximately 250 to 300 grams, and in males it weighs approximately 300 to 350 grams. So it is comprising of roughly 0.4 to 0.5% of the body weight. So it beats 30 to 40 million times per year, and per day it pumps approximately 7,500 liters of blood. So there is no rest for the heart. And the basic components of the heart includes the myocardium, the cardiac valves, the conduction system of the heart, and the coronary vasculature. So disruption of any element of the heart affects the pumping efficiency, and thus leading to the morbidity and the mortality. So the wall thickness of the heart is directly proportional to the pressure. So the left ventricular valve is approximately 1.5 centimeters thick, and the right ventricle is approximately 0.5 centimeter thick. So the left ventricular wall is thicker than the wall of the right ventricle, and the atrial wall thickness is approximately 0.2%. So the heart pumps blood during systole, and it relaxes and allows the blood to be filled through the atria into the ventricle in the diastole. So whenever there is increase in the weight of the heart and thickness of the cardiac valves, then this condition is referred to as the hypertrophy. Whenever there is an increased weight and thickness of the valve, and then whenever there is an increase in the size of the heart or the cardiac chambers, then this entity is referred to as the cardiac dilatation. And whenever there is an increase in the cardiac weight and there is an increased size, so combine in combination, the entity is referred to as the cardiomegaly. So the heart disease is the silent killer, and it approximately causes 100 billion deaths in a year, and 40% of all the deaths are due to the cardiac issues, and 750,000 deaths annually are caused due to the cardiac issues. Now the blood supply of the heart is supplied by the coronary arteries, and these coronary arteries arise from the aortic valve and the sinuses of valsalva. So firstly, there are epicardial coronary arteries that are approximately 5 into 10 centimeters size and 2 to 4 millimeter in diameter, and when they penetrate the pericardium, they become the myocardial coronary arteries. And the two main branches of the coronary arteries are the right coronary artery and the left coronary artery. So the major blood supply of the heart is through the left coronary artery, which is further subdivided into the left anterior descending artery and the left circumflex artery. So the knowledge of the blood supply correlates with the obstruction and the region of MI. So in some person there is right coronary artery dominance, and in some persons there is left coronary artery dominance. These coronary arteries are end arteries. So whenever there is any obstruction in coronary artery, so the region that is supplied by the artery undergoes ischemia and subsequently it is infarcted. So because of the different types of anastomosis, the collaterals open up with ischemia so that the blood supply should not be compromised. But because these are end arteries, so any damage or complete obstruction of artery may lead to infarction. So this is the photograph demonstrating the blood supply of the heart. The right coronary artery is traveling between the right atrium and the right ventricle, and it has the major branch that is referred to as the marginal branch, and then the left coronary artery is subdivided into the left anterior descending artery that travels between the right and left ventricle, and the left circumflex artery that travels between the left atrium and the left ventricle. This is another photograph demonstrating the blood supply of the heart, the right coronary arteries and the left coronary arteries with their corresponding branches, the marginal branch of the right coronary artery and the anterior interventricular branch and the posterior interventricular branch of the left anterior descending artery. So now coming to the structure of myocardium, the myocardium undergoes coordinated contraction during systole and the relaxation during diastole. So the left ventricular myocytes are arranged circumferentially in a spiral orientation. They have a more circumferential and coordinated and arrangement as compared to the right ventricular myocytes. So the ventricular myocytes are composed of a series of subunits that are referred to as the sarcomeres, and the sarcomeres are comprising of the thick myosin and the thin actin filaments and the regulatory proteins that are referred to as the troponin and the tropomyosin. So these myosin and the thin actin filaments partially overlap uh, on one another, leading to the striated appearance of the cardiac myocytes. So this is the basic structure of the uh, cardiac myocytes. Whenever there is excessive dilatation of the heart, the overlap of these actin and myosin filaments is reduced and the force of contraction decreases, leading to the heart failure. So the atrial myocytes have cytoplasmic electron dense storage granules that contain the special hormone that is referred to as the atrial natriuretic peptide, and this is the hormone that promotes the arterial vasodilation and stimulates the renal water and salt elimination. So it causes the natriuresis and diuresis, and therefore it helps in regulating the hypertension and the congestive heart failure. So the coordinated contraction of the cardiac myocytes depends upon the intercalated disc and the gap junctions. So the intercalated disc are the specialized intercellular junctions that facilitate the cell-to-cell, mechanical and the electric coupling. So within the intercalated disc, the gap junctions facilitate the synchronized wave of the myocyte contraction. So abnormalities in the distribution of gap junction results in the variety of heart diseases, including the arrhythmias or the heart failure. So this is the diagram showing the striated appearance of the cardiac myocytes, the nucleus and the intercalated disc, and the basic components that are present within the cardiac myocyte: the sarcolemma, the mitochondria, the endothelium, the fibroblast, and the atrial natriuretic peptide. Now the conduction system of the heart is composed of the sinoatrial node, which is present at the junction of the superior vena cava and the right atrial appendage, and this sinoatrial node is the pacemaker of the heart because it stimulates the contraction of the myocardium. And then is the atrioventricular node, which is present along the interatrial septum, and it transmits the force of contraction through the atria to the ventricle, and it has a gatekeeper function, and it delays the transmission of signals from the atria to the ventricles and ensures that the atrial contraction precedes the ventricular systole. And then the AV node further subdivides into the bundle of His, which connects the right atrium to the ventricular septum, and the subsequent divisions of the right and left bundle branches into the ventricles constitute the further arborization into the Purkinje network. So the coordinated contractions of these cardiac conduction system enables the heart to function properly. Now the cardiac valves. The cardiac valves has the ability that they maintain the unidirectional blood flow, and this ability depends upon the mobility and the pliability of the leaflets. So there are two types of cardiac valves: the semilunar valves, which are present between the outflow tract, that is between the left ventricle and the aorta is the aortic valve, and between the right ventricle and the pulmonary arteries are the pulmonary valves. So they have the cusp, and these cusp fill up in systole and close in systole and fill up in diastole. And then the atrioventricular valves, as the name indicates, they are present between the atria and the ventricle. The mitral valve is present between the left atria and the left ventricle, and the tricuspid valve has three cusps, and it is present between the right atrium and the left ventricle and the right ventricle. So these valves have delicate chordae tendineae and the attached papillary muscles. So whenever there is dysfunction of any component of the atrioventricular valves, whether they are the leaflets or the chordae tendineae or the papillary muscles, so it may lead to the heart diseases. So these semilunar valves and the atrioventricular valve are tri-layered. The first layer is the layer of fibrosa, that is the dense collagenous core at the outflow surface, and then the inner surface, the inflow tract is composed of a layer rich in elastin, and then the middle core of loose connective tissue that is referred to as the spongiosa. So the pathological changes of the valves are largely of three types. Whenever there is damage to the collagen layer, that is the outflow tract layer, it weakens the leaflets, and it basically is exemplified by the mitral valve prolapse. And whenever there is calcific deposits in the form of nodular calcification in the interstitial cell, then it may relate to the calcific aortic stenosis. And whenever there is fibrotic thickening of the layer of fibrosa, then it is a key feature in the rheumatic heart disease. Now, some of the effects of aging on the heart. There are different effects of aging on different components of the heart. So first, what happens to the chambers with age? There is increase in the left atrial cavity size. There is decrease in the left ventricular cavity size, and the ventricular septum becomes sigmoid shaped. So this is the diagram showing the decrease in the left atrial cavity size and then the sigmoid shape, the interventricular septum. Now what happens to the valves? The calcification occurs of the aortic and the mitral valve, leading to the aortic valve calcific deposits, the mitral valve's annular calcific deposits, and then the fibrous thickening of the leaflets and the buckling of the mitral leaflets towards the left atrium. So these are the changes that occur in the cardiac valves. Now coming to the coronary arteries, the coronary arteries become tortuous. They have increased cross-sectional luminal area. Calcific deposits occur within the arteries, and the atherosclerotic thickening of the arteries occur with advancing age. Now what happens to the myocardium? The myocardium has increased mass. There is increase in the subepicardial fat, and then brown atrophy, the lipofuscin deposition, the basophilic degeneration, and the amyloid deposition occur. So what is the basophilic degeneration? It is a grave product of glycogen metabolism within the cardiac myocytes that is increased with age. These are the changes that occurs in the aging heart. So this is the normal myocardium, the structure of the normal myocardium. As you can very well appreciate the striated appearance of the cardiac myocytes. And this diagram shows the brown atrophy of the heart. The deposition of the lipofuscin pigment is highlighted by the arrows, the brown pigment deposition within the heart.